Hello friends, I am Dr. Farheen and let's do a rapid revision of gestational trophoblastic diseases. So what are gestational trophoblastic diseases? They are a group of conditions which are due to the abnormal proliferation of the trophoblast cells of the placenta. Okay, so it can either be a benign condition which presents as a H-mole, which can either be partial or complete, or it can present as a gestational trophoblastic neoplasia, which are malignant conditions, and it comprises of either the invasive mole, which is most common of this, or choriocarcinoma, which is the second most common condition, and other rare causes which can be placental-side trophoblastic tumor or endothelial trophoblastic tumor. An important point to note here is that the benign condition, which is the partial or the complete mole, can also get converted into a gestational trophoblastic neoplasia. Therefore, we have to monitor these patients by beta HCG levels. Okay, and the chances of conversion is much higher in complete mole than with the partial mole. Okay, so what is the pathophysiology behind the H mole? Okay, so H mole can either be a complete mole, right, or it can either be a partial mole. Okay, so in partial mole, what happens that the sperm fertilizes with an egg and it leads to formation of a triploid zygote. Okay, so this is triploid and it contains both paternal and maternal chromosome. In complete mole, what happens that there are two conditions. Okay, the most common is the condition in which a single sperm fertilizes an empty ovum. Okay, so in complete mole, it's always the ovum which is empty. So it fertilizes an empty ovum. This sperm duplicates and it forms a zygote. Now this zygote is diploid, okay, and it is only of paternal condition. It is diploid and it is only paternal in nature. Okay. The second scenario seen in 20% cases is that the two sperms can again fertilize an empty ovum and it can lead to a diploid zygote and the material will be paternal. Now there are 2 points to note over here, that since the complete mole forms is only of paternal origin, so therefore will be no fetus formed. Okay, so no fetal tissue will be present in the complete mole, right? Whereas in the partial mole, the fetal tissue might be present. Okay, there is this another P57 stain. Now it stains positive only when the maternal chromosome is present. Okay, so it will be negative in a complete mole, alright, while it will be positive for a partial mole. Third thing, complete mole, there are increased chances of getting converted into a gestational trophoblastic neoplasia, right? The beta HCG will be of much higher levels in the complete mole. Okay, so let's summarize the chart once again. Partial mole is triploid and it can be both maternal plus paternal, right? Complete mole is diploid and it is only of paternal origin. Since it is only of paternal origin, no fetal tissue is there, no amnion or fetal erythrocytes will be there, right? There will be diffuse proliferation of the trophoblast, so villus edema will be diffuse proliferation of the trophoblast, and P57 immunostaining, which was negative because there is no maternal part. Now there is increased chances of gestational trophoblastic neoplasia, right, which is 15% in complete mole and 1 to 5% in partial mole. They can also ask this question in a different manner, that in which mole there is increased chances that the patient might require chemotherapy. Okay, so again in complete mole the patient might require chemotherapy. Okay, so chances of getting chemotherapy is much more. Theca lutein cysts, what are that? So what happens that the beta HCG levels, they stimulate the ovaries and they make it enlarged and cystic. They are known as the theca lutein cysts. Since the beta HCG level is much higher in the complete mole, so the chances of forming a theca lutein cyst again is much higher in the complete mole. Alright. Now how is the patient going to present to us? First of all, she would have missed her period, so there will be amenorrhea or her UPT will be positive. Then she will say that she's been passing grape-like vesicles from her vagina. And when you do the ultrasound, then the ultrasound is pathognomonic of the diffuse proliferation of the placenta. Okay, so this is the main presentation of these patients. Other symptoms is that we know that the beta HCG is very high, right, in molar pregnancy. Now this beta HCG also mimics TSH, okay. So this TSH level is also going to be high, which will manifest as hyperthyroidism, okay. So this patient can have tachycardia. Tachycardia is also seen normally in pregnancy. They can have tremors, right. There will be hyperemesis again because of increased beta HCG levels, excessive abdominal distension, right, and early onset preeclampsia. So this patient will present with increased blood pressure and proteinuria at less than 20 weeks, before 20 weeks, okay. So that is early onset preeclampsia. Other rare presentation is that the patient can have hemoptysis because of metastasis to the lungs, or she can have respiratory failure, or there can be seizures because of metastasis to the brain, okay. So what is the diagnosis? Diagnosis again is beta HCG, okay. Diagnosis is by beta HCG, and ultrasound will show the typical snowstorm appearance. This they have also asked the question that the patient presented to with passing of grape-like vesicles, and on ultrasound there was snowstorm appearance. So what is the diagnosis? Diagnosis is molar pregnancy. Another point, these are the theca lutein cysts, which can be seen on the CT over here, that this is the enlarged ovary and it has become multicystic. See, so these are the theca lutein cysts, okay. Here I would like to say that the mainstay of diagnosis is histopathology. So histopathology is that when you have evacuated the womb of the patient and you have sent the tissue to the lab, that is histopathology, and only histopathology can confirm whether it's a molar pregnancy or a non-molar pregnancy, okay. And in the molar also, what is the type? It is only the histopathology which is going to diagnose, okay. So what is the management? Management is suction and evacuation of the molar pregnancy. So what do we do is that this is known as the Carman's cannula, okay. So this is the Carman's cannula, and at the end of it is a tube which is attached to a suction machine which creates vacuum, okay. So once we put the tube inside, we switch on this machine, a pressure will be created, and all the abnormal tissue, okay, all the molar tissue which is present here will be sucked into this hole, and through this tube it is going to enter a jar over here. From here we will collect the material and we will send it to the laboratory for confirming the diagnosis by histopathology. So this is known as suction and evacuation. Another point to mention over here, that the uterus is extremely friable, so we are not going to use the curettage. We will only do suction and evacuation by the thin Carman's cannula, okay. And if it is done under the guidance of ultrasound, then it is much better because it is going to further decrease the chances of perforation. So the management of choice for any molar pregnancy is ultrasound guided suction and evacuation. So as of now, we are suspecting molar pregnancy just basis the clinical features of the patient, right, plus the ultrasound features which has shown that the placenta is cystic, okay. And now we have sent to the lab for histopathology, okay. So ultrasound guided suction evacuation is the management of choice. Now for complete mole, this still remains the management of choice. For partial mole also it is the management of choice, but the point to remember here is that in partial mole, fetal tissue can also be present, right. So if the fetal tissue is going to be present, then the fetal bones cannot be sucked out through that Carman cannula, okay. And then in that case, medical management will become the treatment of choice, okay. Now what about the use of prostaglandins for cervical ripening? So for doing any procedure, we need to enter through the cervix into the uterus, okay. For that the cervix needs to be soft. We use medications to soften the cervix, and that is known as cervical ripening, okay. So generally misoprost is used. It is a prostaglandin. So what about the use of that? Prostaglandins are not used, okay, and even oxytocins are not used, okay, in molar pregnancy. Why are they not used? Because any drug which which contracts the uterus is not used because the tissue of the molar pregnancy, okay, the grape-like vesicles, so they can go through the uterine veins into the iliac veins and the maternal circulation. They can cause pulmonary embolism and they can get disseminated into the other parts of the body also. We also don't know whether it's a gestational neoplasia or not, and we are increasing the chances of metastasis also. Alright, so therefore any agent which contracts the uterus is not used. So neither prostaglandin nor oxytocin. But another point to remember over here is that what if the patient is bleeding? Okay, so you have done the procedure and now the patient is bleeding profusely. So after doing the procedure, after you have evacuated the uterus of the molar pregnancy tissue, then you can give oxytocins. Okay, then only you can give oxytocins, otherwise not. Alright, hope I'm clear. So in a molar pregnancy, we will not use prostaglandins, we will not use oxytocins, and we will not do curettage. Okay. So post evacuation, what are we going to do? We are going to send the product of conception for histopathology for confirmation of the diagnosis. If the patient is Rh negative, give her anti-D. Okay, never forget to give anti-D to a Rh negative patient. Now there is this logic that people give, what about complete mole? So complete mole does not have a fetal tissue, so we need not give anti-D to these patients. That is correct. But when are you going to know that it's a complete mole? Only after a histopathological diagnosis. The report of that is going to come after 2 to 3 days time. And what is the time limit when you have to give anti-D? It is within 72 hours. So for all practical purposes, we give anti-D to all patients irrespective of the fact before the confirmation of the diagnosis, because there is no harm in giving that to them. Alright. So now we also do serial follow-up of beta HCG of these patients. This is the very important and the most important follow-up. Okay. So most important follow-up is the serial follow-up with beta HCG in these patients. So how do we follow up the beta HCG? We have complete mole and we have partial mole. Okay, so first let's talk about the complete mole, because there are increased chances of the complete mole turning into a gestational neoplasia, right? So we monitor beta HCG either by serum or urine, and we monitor it every 2 weekly till 56 days. Okay, so you have done suction and evacuation. You have sent the tissue for histopathology. On histopathology, it has come that it's a complete mole. Okay. Now from here onwards, every 2 weekly, you will do beta HCG for 56 days. Okay. Now if before 56 days, the beta HCG normalizes, then we will monitor beta HCG every 2 weekly for 6 months. Okay. So 56 days, beta HCG normalizes, again we monitor for 2 weeks for 6 months. Okay. Now what about if it doesn't normalize by 56 days? Okay. Suppose it normalizes by 74 days. Then what are we going to do? Starting from this 74 days, we will monitor the beta HCG again for 6 months 2 weekly. Okay. Hope I'm clear about this. Now what about partial mole? Partial mole, we monitor beta HCG till it comes out to be normal. Suppose it has come out to be normal on 14th week. Okay, it has come out to be normal. Then again after 4 weeks, on the 18th week, again we will do the beta HCG. If it again comes out to be normal, then we will discharge the patient. So this is the follow-up for partial mole. Okay. Now what on histopathology, it has come out that it is a gestational trophoblastic neoplasia. Okay. So then FIGO came out with a classification to classify whether this gestational trophoblastic neoplasia is low risk or high risk. Okay. So you have sent the histopathology. In that, it came out that it's a gestational trophoblastic neoplasia. It can be any of the 4 conditions: invasive mole, choriocarcinoma, PSTT, or endothelial trophoblastic tumor. Here I would like to mention that PSTT is only condition in gestational trophoblastic neoplasia which is chemo resistant, and in those patients we only do surgery. Okay. So if it has come out to be gestational trophoblastic neoplasia, we classify them as low risk or high risk. Okay. So if the FIGO score, FIGO has given the score as 0, 1, 2, 3, 4, So if the FIGO score is less than 6, it is low risk. If it is more than equal to 7, then it is high risk. Okay, so they have been asking recently questions on the FIGO classification. Let's go through this. It might look jumbled initially, but I will try to simplify it for you. Alright, so starting with this, if the age of the mother is less than 40 years, then she's at low risk, we give a 0 score. But if the age of mother is more than 40 years, then she's at a higher risk. Okay. Now, what do we mean by antecedent pregnancy? It means that if the gestational trophoblastic neoplasia has been detected after a molar pregnancy or after any normal abortion or after a live birth. Okay. So, if after any pregnancy event, patient continues to bleed, so what do? We offer a transvaginal scan. First of all, the most common condition after any abortion is that there can be a retained product. Okay, just in case if there is no retained product, we go for a beta HCG. If the beta HCG levels come out to be higher, okay, then we detect that it can be a case of gestational trophoblastic neoplasia. So if it was a live birth and now it has been diagnosed of a GTN, then the risk is much higher. Okay. Now, interval months from the end of the index pregnancy, whatever the pregnancy was, okay, molar pregnancy, abortion or live birth, from that point, what was the point when the GTN was detected? If it was less than 4 months, the risk is 0. But if it is more than 13 months, then the risk is very high. Okay. What is the pre-treatment serum beta HCG level? Okay. So, what was the beta HCG level before evacuation of the molar pregnancy? If it is less than 10 raised to power 3, it is low. But if it is more than 10 raised to power 5, then it is said to be high. Okay. Again, the largest tumor size which is present in the uterus, if it is less than 3 cm, it is low. If it is 5 cm, the score is 2. The site of metastasis, if it is lung, then the score is lesser. But if it has metastasized to the liver and the brain, then the score is much higher. What is the number of metastasis? If it is more than 8, then again the score is higher. Previous failed chemotherapy. Patient has already been diagnosed of GTN. She had been on chemotherapy. If the chemotherapy has failed, whether it was a single drug chemotherapy or a multiple drug chemotherapy. If it was a single drug chemotherapy, the score is lesser, but if it was a multiple drug therapy, then the score is higher. Okay, so basically it is nothing but if you just try to put in your thoughts together, one thing leads to another. So again, age more than 40 years, definitely the patient will be at higher risk. If it was a live birth, if there was no risk factor before that, it's live birth, now it has been detected as GTN, again the risk will be higher. The more you go, the more you delay treatment, the risk is going to be higher, right? Pre-treatment beta HCG, we all know that the higher the beta HCG, the risk is going to be higher. Okay, and previously failed chemotherapy. These are the things which you just might need to remember. Okay. Now, if the patient is low risk, what do? We give her single dose chemotherapy of methotrexate. Okay, single drug. Okay, and if the patient is high risk, then we give her multiple drug chemotherapy of Imaco regimen. Okay, so how are we going to give this? So if FIGO classification is less than 6, then what are we going to do? We are going to alternate single injection of methotrexate with folinic acid. It is also known as leucovorin rescue for 1 week. Okay, so one day we are giving methotrexate, next day we are giving folinic acid. Okay, methotrexate, folinic acid, and similarly like this. Now after this, we are going to take a rest for 1 week or 6 days. Meanwhile, we are also going to get the beta HCG of the patient done every 2 weekly, right? And for how long are we going to give this chemotherapy cycle? So we will give this chemotherapy cycle till 6 weeks post normalization of beta HCG. Okay, so if the beta HCG has normalized on 70th day, suppose, then after still 6 weeks, we are going to give her chemotherapy. Alright. If the FIGO scoring is more than 7, then we go for the Imaco regimen. Okay, E is for etoposide, M is for methotrexate, A is actinomycin, C is cyclophosphamide, and O is vincristine or oncovin. Okay. Now, if the patient is on chemotherapy, she is asked not to conceive till 1 year post chemotherapy because there are increased chances of miscarriages in these patients and malformations. Okay. And in the next pregnancy, she is instructed that she has to get her beta HCG done 6 to 8 weeks after the pregnancy event. So what do we mean by that? If next pregnancy is an abortion, okay, or again if it's a live birth, then after delivery or after MTP, 6 to 8 weeks after this, she will send her sample for beta HCG, because there can be increased chances of recurrence. Okay. Now what about contraception? Okay, so why is contraception required in these patients? Because just in case if these patients get pregnant, the beta HCG is again going to rise high, and it is going to give high false values of beta HCG, and we might not be able to monitor these patients properly. Okay, so we ask patients to use barrier contraception till the beta HCG normalizes. After the beta HCG has normalized, then oral contraceptive pill is the contraception of choice. So this is the contraception of choice. Okay, what about IUCDs? IUCDs are totally contraindicated. Why? Because these patients have a friable uterus, and if you're going to insert anything inside the uterus, there's a very high risk of perforation. So IUCD is one thing which is contraindicated. Another thing is that people say that they can use oral contraceptive pill even before the beta HCG has normalized. They can use it, but it was seen in a randomized controlled trial that there were increased chances of patient getting converted into a gestational trophoblastic neoplasia. Okay, so therefore it is advised, it is very clear that till the beta HCG normalizes, we use barrier contraception. After that, oral contraceptive pill is the contraception of choice, and IUCD is contraindicated. Okay, now let's talk about other gestational trophoblastic neoplasia conditions, just salient points about them. So what is an invasive mole? It is a penetration of molar tissue, either the complete or the partial mole, into the myometrium of the uterus. Okay, so this is the uterus, your cervix, and inside the cavity, suppose this was the molar pregnancy, so it has now penetrated into the myometrium. Okay, even the serosa. So this is the invasive mole, as the name suggests. And what is the treatment of choice? Treatment of choice is hysterectomy. Okay, choriocarcinoma is again the malignant trophoblastic cancer of the placenta, and the treatment of choice is chemotherapy, or if the patient has completed her family, then she can go for a hysterectomy. Okay, placental site trophoblastic tumor is a very slow growing tumor, and the question which is often asked is that it is chemo resistant. So therefore chemotherapy is not going to work on these patients, and hysterectomy remains the treatment of choice in these patients. Alright, so this was all about molar pregnancy. Thank you so much.